As an act of reconciliation and gratitude, the CLPNA acknowledges the traditional territories where we work and learn. The CLPNA regulates the practice of practical nursing on Treaty 6, 7, and 8 territories. We respect the histories, languages, and cultures of First Nations, Métis, Inuit, and all First Peoples of Canada, whose presence continues to enrich our community and whose ancestors have taken care of the land for centuries. Welcome to this video presentation on communication strategies to support people living with dementia. The CLPNA is pleased to welcome guest presenter Dr. Tammy Hopper from the University of Alberta, Faculty of Rehabilitation Medicine. Tammy is a speech-language therapist and professor at the University of Alberta who specializes in communication with individuals who are living with dementia. Dr. Hopper has more than 20 years of experience in teaching and conducting clinical research with people living with dementia and their care partners, with a focus on individuals living in long-term care settings. Her recent research focuses on hearing loss as it coexists with dementia and practical strategies to improve social interaction and connection. Welcome, Tammy.
Thanks very much. The contents of this presentation are in alignment with the Standards of Practice and Code of Ethics for licensed practical nurses in Canada. Specifically, LPNs are required to demonstrate the knowledge and ability to apply communication techniques to support effective communication to address cognitive barriers. This presentation will define dementia and its most common cause, explain cognitive changes in Alzheimer's dementia, describe communication and how it is affected by the cognitive changes of dementia, and provide specific techniques to improve communication with people who have dementia. I would like to first spend a few minutes defining dementia and talking about its prevalence in Canada and the world. It is important to clarify that dementia is a syndrome that is caused by an underlying disease process. Although there are various frameworks for definitions and criteria for the diagnosis of dementia, all of the frameworks have core criteria for diagnosis, including the following. A. Evidence of significant cognitive decline from a previous level of performance in one or more cognitive domains. B. The cognitive deficits interfere with independence in everyday activities. C. The cognitive deficits do not occur exclusively in the context of a delirium or an acute confusional state. And D, the cognitive deficits are not better explained by another mental disorder, meaning that dementia is often still a diagnosis of exclusion made by the physician. They must rule out other causes of the cognitive deficits and decline as part of the diagnostic process. Once that initial diagnosis is made, the physician will then attempt to determine the underlying disease causing the dementia through a careful history taking, physical examination, blood work, and, when possible, neuroimaging. There are more than 70 known causes of dementia, and some are reversible, so a thorough examination is necessary. The most common cause of dementia by far is Alzheimer's disease, either by itself or in combination with another disease like vascular disease. It causes between 60 and 80% of cases of dementia. When Alzheimer's disease is the primary cause of the dementia, it is generally referred to as Alzheimer or Alzheimer's dementia. We'll talk more about cognitive and communication deficits associated with Alzheimer's dementia further on in the presentation. In 2020, nearly 600,000 people in Canada were living with dementia, and it's projected that by 2030, that number will increase to almost 1 million. Worldwide, there are currently 35 to 50 million people living with dementia, and that number is expected to double every 20 years if a cure or method of prevention is not found. To be diagnosed with probable Alzheimer's dementia, people must present with symptoms that have insidious onset, that is, symptoms have a gradual onset over months to years, not sudden over hours or days, a clear-cut history of worsening of cognition by report or observation, and the initial and most prominent cognitive deficits are generally in memory for recent events, or episodic memory. Attention and problem-solving may also be impaired, as well as language, visual spatial abilities, and judgment. These impairments start as mild and worsen over the course of the Alzheimer's disease process. Now let's spend a minute talking about memory, and in particular episodic memory, because deficits here are at the core of many of the communication problems that people with dementia experience in their everyday lives. When we describe the memory problems of people with Alzheimer's dementia, we might say they are having difficulty with short-term memory. In fact, what we mean is that memory for recent events is impaired, which is called episodic memory. It's called episodic because it consists of memory for episodes in our lives, things we see and do and experience. These episodes can be minor, a conversation you had with your friend on the train to work, or major, attending a family member's wedding. Episodic memory is kind of like our autobiographical memory for our lives. We experience, we encode, and then we can recall what happened at a later time. If we try to recall something 5 minutes after it happened, it will be relatively easy if you have typical cognition, but it can be almost impossible if you have Alzheimer's dementia. By contrast, procedural memory is our memory for how to do things. It involves motor skills, routines, habits like riding a bike, shaking hands, opening a door. This type of memory that is expressed through doing tends to be relatively well preserved until the later stages of decline in dementia. That means there may be strengths upon which we can capitalize when communicating and providing care for individuals with dementia. By now you may be thinking, I know that people with Alzheimer's dementia have trouble with memory and other aspects of cognition, and that they also may have some strengths in procedural memory. But what does that have to do with communication? And I would say that is an excellent question. Let's turn now to a brief overview of communication for some answers. Communication occurs when we send or receive messages or when we assign meaning to another person's signals. Communication is effective and successful when the message we intend to send is accurately understood by another person who then responds appropriately. Those signals or messages can be sent through verbal and nonverbal modalities. Verbal communication consists of the actual words we use to communicate. These words are part of language, and the way that we convey meaning is found in the words that we use and how we put them together in whatever languages we know and use, French, English, Ukrainian, Cree, or Mandarin as examples. Language can be expressed through speech, which is the way the words sound when you say them. Your tone of voice, how fast and how loud you talk are all a part of speech. When someone uses speech to convey a message, the person receiving that message must have intact hearing to be able to process the sound and understand the meaning of what is being said. Language may also be expressed in text, that is, by writing down words, sentences, and paragraphs on paper or typing them in electronic format to be displayed on a screen. When language is expressed through text, the person seeing that text must be able to read it to understand its meaning. Nonverbal communication consists of all other communication that does not involve actual words in either speech or text. For example, facial expression and eye contact, touch, body position and proximity, how close you are to someone, as well as gestures, are all powerful ways of communicating. Take a moment to look at each of the pictures on this slide. Without any labels, I'm sure you can understand at least something about the feelings of the people in the photos by looking at their facial expressions and posture, and you might be able to guess at their levels of familiarity, how well they know each other, simply by looking at how close they are sitting and if and how they are touching. What's important to note here is that nonverbal communication is often expressed through procedural memory, motor skills, and habits. I also want you to notice that little emoji that I put on the bottom of the slide. Increasingly, we are seeing graphics like this used to communicate emotions, often in smartphone texts that we send back and forth, or in emails or on web pages. An emoji is also an example of a form of nonverbal communication, just as a picture or a drawing might be. As the old saying goes, a picture is worth 1,000 words. Even though we have many different ways of communicating at our disposal, we often resort to speaking and listening. taking turns in conversation to accomplish our daily tasks, exchange information, make our own needs and feelings known, provide care, and connect socially with others. Indeed, much of our daily interactions are based on events in our recent past or in the near future, what we have done and what we plan to do next. Think about the last face-to-face interaction you had at home or work. What did you talk about? For most of us, the topics will be something that require the use of episodic memory. Questions like, how was your weekend? How is your family? When did your symptoms start? What have you got planned for dinner? Open-ended questions about time-based information. Because this type of communication is heavily reliant on episodic memory, and we know that episodic memory is impaired early and significantly in Alzheimer's dementia, people with dementia will have difficulty answering these questions, as it requires remembering what they or others have recently said or done, remembering their intentions, staying on topic in a longer conversation, and understanding longer or complex directions or ideas. There are other conditions that also contribute to communication breakdowns. Hearing loss is a common one. In fact, more than a quarter of people aged 55 to 64 have a hearing loss significant enough to interfere with spoken communication. And after 75 years old, that percentage jumps to 50. So fully half of older adults with dementia will have a disabling hearing loss. We know that hearing loss often goes undetected in people with dementia because the signs and symptoms of hearing loss overlap with those of dementia and vice versa. For example, in the table below, you will see the overlap of several common communication problems that can be caused by dementia and by hearing loss on its own. Then, when you have dementia co-occurring with hearing loss, which it often does, you have a problem-on-problem type of situation. We have talked a lot about deficits and impairments, but what about strengths? People with dementia may still be able to do the following until later stages. They may be able to read short phrases and words aloud, recognize pictures and people, reminisce about the past, sing and play a musical instrument, and have a simple conversation with appropriate support. Importantly, all individuals have a need for human interaction. So how do we leverage these strengths? And if you look at this list, you'll see that many of these relative strengths are related to procedural memory, motor skills and habits. Even reading is considered to be and draw heavily on procedural memory. So how do we leverage these strengths to improve communication? We know that communication can take several forms. We've learned that already, and we need to use different verbal and nonverbal modalities to help support communication for people with dementia and facilitate them being able to demonstrate what they can still do. Multimodality communication is important. So let's go over a few of these specific strategies. You can use visual and graphic cues, memory books and wallets, and memory reminder communication cards. You can also use specific ways of speaking and connecting. You can simplify, use clear speech, and validate feelings and beliefs expressed by people with dementia. And finally, you can make changes to the setting in which you communicate. So let's discuss these strategies in more detail. The first is creating visual and graphic cues like memory books and wallets. These are small books or albums with labeled photographs of familiar persons, places, and events, designed to present factual information in written and picture format. The photographs and descriptors are tailored to the individual. So this is very person-centered. Why do memory books and wallets work? Well, first, they're tangible stimuli. You can see them and touch them and hold them in your hands. Thus, using this type of tangible stimulus item reduces demands on impaired episodic memory. Also, the books and wallets tap into recognition memory and memory for the remote past with the pictures and the words accompanying them. And finally, they use personally meaningful pictures and stories to evoke positive emotion, communication, and behavior. Even in the middle to late stages, Many people with dementia can respond appropriately to single written words, short phrases, and familiar pictures. You can use the following conversation prompts while going over a memory wallet or book with someone. First, ask the person to have a conversation with you. This is a sign of respect and lets them know they have a choice. Second, guide the conversation to specific topics and redirect the conversation back to the topic if the person begins to ramble. Third, reassure and help out when the person gets stuck or can't find the word they want to use. Fourth, smile and act interested in whatever the person is talking about, even if you're not quite sure what they're trying to say. And then thank the person for talking with you. It is important to not quiz, correct, or contradict the individual during your conversation. Remember, the focus is on a positive social connection, not really the accuracy or truthfulness of what is being shared by the person with dementia. In addition to facilitating social interaction and conversation, written and graphic cues may also be used to remind people of important information. Michelle Bourgeois and colleagues refer to these as memory reminder communication cards. A common symptom of episodic memory impairment is repeatedly asking the same question, even if it has been answered many times. Care partners report that this is a distressing symptom that can create increased care burden over time. By writing the answers on a card, people with dementia will have access to those answers, and the frequency of question asking may be reduced. So how does it work? Here's an example of a memory reminder communication card used by the spouse of a man with dementia who would repeatedly ask, "What is today? What are we doing? Do we have anything on?" he would say. So what she did was she wrote the answers to these frequently asked questions on the card, then pointed to the written cue and had the person read the answer aloud, and she did that with her husband. Then she set the card in a place where her husband spent time and passed through frequently. In this case, she left it on the table in the kitchen. But you could also use a wipe-off board and attach it to, say, the fridge, or have a card like this sitting next to the person's chair in the living room. The second general strategy to improve communication is to use specific ways of speaking and connecting. So the first specific strategy I would like to talk about is simplifying. Simplifying sentences and explanations. Complex sentences tend to be longer and harder to remember, and people have to hold the sentence in mind while trying to make sense of it. So if you simplify sentences and explanations by making long, complex statements shorter and using concrete words paired with gestures, you are reducing demands on those impaired memory systems we've discussed, and you're using nonverbal communication to reinforce your spoken message. An example of a sentence that is too long and complex would be, "Let's try this. Why don't you come with me and we'll see about that cushion? It's almost time for lunch, so we should hurry if we want to get it done today." A better way to say it would be, "May I fix your cushion?" and touch the cushion while you are saying it. So you have the verbal and the nonverbal. Simplifying questions is also important. As I mentioned earlier, difficult questions are open-ended and often require free recall or generative answers. And we often ask these types of questions in our conversations. Open-ended free recall questions such as, "Of the places you have visited, what are your favorites?" Or an open-ended generative question, "What should we buy Lee for her birthday?" Easier types of questions give two choices for the person to select from. So in this case, the two-choice question could be, "Did you like Hawaii or the Caribbean islands better?" And "Should we buy Lee a necklace or a clock for her birthday?" You can also use yes-no questions. These are questions that people can answer simply with a yes or a no. "Do you like to travel?" Or "Do you want to buy Lee a necklace for her birthday?" Both give the individual with dementia an opportunity to participate in the conversation in a meaningful way. The second strategy I would like to discuss in terms of increasing communication success is called clear speech. Clear speech is when the speaker attempts to express every word and sentence in a precise, accurate, fully formed manner. It is naturally slower and louder, more lively, with a full range of intonation and stress on key words, and it's characterized by pauses between phrases. Clear speech works because it reduces the cognitive effort of trying to understand what is being said and does not distort the sound of the speech like yelling does. The wonderful aspect of clear speech is that it works to increase understanding of speech by people who have hearing loss and dementia, which we know commonly coexist. So how do you do it? It's deceptively simple. The reason I say that is because it's fairly straightforward but requires practice. You emphasize keywords, break sentences down into natural phrases, and insert pauses at natural points. Also, speak naturally. There's no need to raise your voice or over-articulate. Here are a few examples so that you can hear the difference between the rate and loudness of regular speech and clear speech. In normal conversation, the first sentence sounds like this: the ship left on a 2-week cruise. In clear speech style, it sounds like this: the ship left on a 2-week cruise. In a normal conversation, the second sentence sounds like this: we're looking for a white truck to buy. In clear speech style, it sounds like this: we were looking for a white truck to buy. Now, practice clear speech using the following examples. Remember to emphasize the keywords, break the sentences down into natural phrases, and insert pauses at natural points. Check that your voice sounds natural. The final technique related to using specific ways of speaking and connecting is to validate feelings and beliefs. So what is validation? Validation is a way of speaking and acting that affirms the reality of the person with dementia and attempts to understand the feelings of their experience. Through validation, one tries to discern meaning and feeling of the communication rather than correcting misinformation or focusing on accuracy. Validation is the acceptance of the reality and personal truth of another's experience. Validation takes into account that people with early to middle stage dementia may be confused about time, place, and situation, and they may make statements that are untrue. They may not recall the specific nature of the mistake, and they will not recall the details of the correction because of the episodic memory deficits that we've discussed. Trying to repeatedly correct the person may create negative feelings, and it won't help them remember. So validation works because rather than correcting or arguing with the person, you're validating their beliefs and feelings, creating a situation that focuses on positive emotion and action. Some validation techniques you can use are making eye contact, using a positive tone of voice, mirroring or repeating the person's words, facial expressions, and general tone, and redirecting the person to an enjoyable activity. Here is an example of validation in action. A person with dementia says, "I'm having lunch with my mother today." You, in response, make eye contact, mirror the positive emotion and validate. "You are having lunch with your mother today? You seem happy about that." And then redirection. "Let's look at your memory book. There is a picture of your mother right here." You see how you're pairing the validation with the written and graphic cues in this communication. Connect versus correct is a great way to remember the validation approach. The final strategy we will discuss today is to modify the communication environment or setting. Remember, we are using multiple modalities to communicate, and we will often still need to use speech. There are some steps you can take to make it easier to understand and be understood, particularly in communal living environments or public spaces. First, have a pen and paper handy. Remember, this is very helpful if you want to use written or graphic cues on the spot. Make sure the person can see your face. So you want to be in a well-lit space, and especially for people with hearing loss, they need to see your face and your lips, so the light needs to be on you. I have an asterisk there because I know that in many healthcare settings and many other public places, we are still wearing masks. And in that case, the person's not going to be able to see your mouth and lips, but they certainly can still see your eyes in terms of making eye contact. And here is where using nonverbal strategies as well as written words is very helpful. Speak clearly and use short sentences and explanations, so again with clear speech. Stress keywords and write them down. That's where your pen and paper are coming in handy. Repeat yourself if necessary and rephrase using different words. Do not yell or shout. Use gestures, facial expressions very freely, that nonverbal communication. And turn down the TV, radios, fans. Reduce background noise as much as possible. In summary, I would like you to please remember that dementia is most commonly caused by Alzheimer's disease. Dementia causes cognitive and communication problems, but not all areas of cognition and communication are affected equally. We can improve communication with people who have dementia and hearing loss by using specific strategies that compensate for deficits and focusing on existing cognitive and communication strengths. And connection is always more important than correction in creating positive communication interactions. I end with this quote that really resonates with me in my interactions with people living with dementia. Human connection lies at the heart of human well-being. It's up to all of us to maintain bonds where they're fading and create ones where they haven't existed.
Thank you for the interest you have taken in this important topic. Licensed practical nurses are regulated professionals who are committed to providing safe, effective, compassionate, and ethical care to members of the public. To do this, LPNs are required to consistently maintain and enhance their competence in nursing practice and be aware of strengths and areas in need of improvement. Please use the Ask CLPNA link on the CLPNA website to submit any questions you may have with regards to this video presentation.